Hello everyone. In this video, we'll discuss step-by-step analysis of kidney function test. Kidney is a very vital organ in our body, so we should be aware of which parameter indicate renal failure. So let's understand what will be the indication of getting the kidney function test done, what are the key parameters which are to be assessed, and approach, along with some real case discussions. Indication. So in OPD, you will be taking a history of symptoms of renal failure. These symptoms are oliguria. Oliguria means urine output will be less than 400 ml per day, or whatever was the urine output of the patient, so that must have decreased from the previous baseline values. So oliguria means urine output of less than 400 ml per day will be present. Puffiness, especially this puffiness will be morning puffiness, and it decreases by the evening time, and mainly it is the facial puffiness which occur first, followed by the other part of the body getting edema. Hematuria will be there, and patient will complain of either gross blood or cola colored urine. So cola colored urine or gross red color blood will be there. Then there will be symptom of fatigue. Fatigue has multiple causes, like there will be erythropoietin deficiency leading to anemia. Patient will feel fatigue, and per se azotemia or renal failure directly leads to fatigue. And this you can see in our other video, the approach to a case of fatigue, in which one of the common cause was renal failure. Risk factors, always ask for the risk factor for kidney disease. Number one risk factor is diabetes. Diabetes indeed is the most common cause of chronic kidney disease, not only in the world but also in India. Most common cause of CKD is diabetes. History of hypertension, uncontrolled hypertension, and a very important, family history of chronic kidney disease will be there, or autosomal dominant polycystic kidney disease. Now the key parameter which we assess are the blood test. So in the blood test, number one and most commonly used is a serum creatinine levels. Second is the blood urea nitrogen. Blood urea nitrogen is equal to blood urea divided by 2 approximately. Some of the lab they just do the urea, so you have to calculate the blood urea nitrogen. Estimated GFR. So the formula for the estimated GFR is popularly known as a Cock-Graf-Gault formula, which is 140 minus age of the patient multiplied by weight divided by serum creatinine into 72, and multiply this by 0.85 for females. So this is a formula which is easy to calculate in the OPD, and nowadays software are there, EMR software for the clinics, in which you just put the age of the patient, weight, creatinine, and they will calculate the eGFR. This is a very important parameter, and it can be ignored in the OPD. Just by looking at the creatinine, we can't tell ki patient is at a risk for CKD or not, but with the eGFR we can determine that patient is going into CKD. Electrolytes will be assessed. Important electrolytes will be sodium, potassium, and bicarbonate. Other parameter which we can assess are uric acid and phosphorus. Both will be elevated in renal failure. Now coming to the urinary test. So urinary tests to be done are simple urine analysis. Dipstick, we go for the proteinuria, or we go for the RBC or RBC cast in the microscopy. This is very important, albumin to creatinine ratio, one of the parameter which is missed in a routine OPD. So this can be done as a spot investigation. No need for any early morning sample, second morning sample, or random. It can be given random. No need for any fasting is needed for this test. Imaging, ultrasound and CT will be if needed. So one by one. Serum creatinine. Normal range in maximum labs, it is 0.6 to 1.2 milligram per deciliter. Clinical significance, it is increased in impaired GFR like acute kidney injury or CKD patients, but it can be affected by muscle mass. If the muscle mass is more, creatinine can be more. Age. With age, serum creatinine increase because the GFR reduces. It is also dependent on the diet, like high protein diet can cause increased creatinine levels. So the formula which we have discussed earlier is the Koch-Graf-Gold formula, or it can be the CKD-EPI or MDRD equation, which are tough to calculate in the OPD, but in the software they can be easily calculated. And simple parameter is this parameter EGFR calculation, Koch-Graf-Gold formula, that which we had discussed in the previous slide. Now blood urea nitrogen normal range is 7 to 20 milligram per deciliter. Clinical significance is it will be increased in dehydration. This is known as a pre-renal AKI, or high protein intake or GI bleed can cause the elevation of blood urea nitrogen. Very importantly, it can be decreased in liver disease or malnutrition. So in the liver disease, why it is reduced? The reason is in the liver disease there will be impairment of urea cycle. So if there is an impairment of the urea cycle, urea will be less synthesized from the ammonia in renal failure, so in liver failure. So therefore the urea will not be produced much. Malnutrition, again there is a less of protein or diet starvation is there. Malnutrition, it will be a decreased blood urea nitrogen. Now this is an important ratio, blood urea nitrogen upon creatinine ratio. So this ratio will be more than 20:1 in pre-renal AKI. So in pre-renal AKI, what happens that the tubules are normally functioning. It is only the dehydration which is causing the renal failure. So here what happens that the serum creatinine can be excreted by tubules normally. So you can see blood urea nitrogen will be increased, but creatinine level will not be that increased because some part of the serum creatinine is excreted by the tubules into the urine. So the serum creatinine will not increase to that extent as blood urea nitrogen. So this will be more than 20:1. While it will be less than 10:1 in intrinsic renal disease where the tubule dysfunction is there. So any intrinsic where the tubule dysfunction is there, creatinine is not excreted out. So the level of the creatinine will also increase severely in cases of the conditions which leads to tubular dysfunctions, that is intrinsic renal disease. Now serum sodium normal range is 135 to 145 and it will be low in renal failure. The reason is it is a dilutional effect, that more water retention is there, that will dilute the serum sodium. Serum potassium normal range is 3.5 to 5.5 and it is usually elevated in renal failure because of decreased glomerular excretion of the potassium. So level will be high. Serum bicarb normal range is 24 to 28 and it will be low in CKD patient because the reason is simple. In the CKD patient, tubules are not working and the function of the tubules is to reabsorb the bicarb. So tubules will not be able to reabsorb the bicarb, so the blood level of bicarb will be decreased. So there will be metabolic acidosis. Uric acid levels, serum uric acid level normal range is 4 to 7, 4 to 6 in females and 4 to 7 in males. And it will be elevated in any sort of renal failure and starvation or dehydration. This is very important. Patient has got diarrhea, vomiting and came with a high uric acid level. So this is due to the dehydration effect. Now hemolysis, uric acid can be increased due to increased cell turnover. Tumor lysis syndrome, again because of increased cell turnover. High protein diet do lead to high uric acid level. So besides the intrinsic renal failure, there can be other causes of the high uric acid level. So history is very important. Phosphorus normal range is 2.5 to 4.5 and it is elevated in CKD because of decreased glomerular excretion. So the level of phosphorus will be high and this is very important because high phosphorus stimulate parathyroid hormone and parathyroid hormone has a deteriorating effect on the bones. Urine analysis, we go for the proteinuria. Glomerular disease damage will be indicated in the proteinuria. Hematuria will be seen in glomerulonephritis or stones, glucose in diabetes. Microscopy, red cells will be seen in glomerulonephritis or stones. White cells will be in infections, and cast will be seen in acute tubular necrosis, and RBC cast will be in glomerulonephritis. So this will be the importance of getting the microscopy done. While this parameter is very important, albumin to creatinine ratio. So normal range is less than 30 milligram per gram of creatinine, and microalbuminuria is 30 to 300. So this is a early diabetes nephropathy. So this will indicate early diabetes nephropathy. Macroalbuminuria will be more than 300, and at macroalbuminuria the urine dipstick will be positive, while in microalbuminuria urine dipstick is negative. Ultrasound will be done when there is a suspicion of CKD to see whether there is any hydronephrosis or whether there is a bilateral shrunken kidneys. CT scan for some stone or renal masses. Now let's see the approach. So the number one, whenever patient come to you with azotemia, that is means creatinine is high, urea is high, look at this ratio. Blood urea nitrogen, serum creatinine is high. So this will be suggestive of, this is suggestive of azotemia. Now, azotemia can have multiple reasons. It could be a pre-renal. AKI means patient has dehydration, hypovolemia. That can also lead to the elevation of these parameter. But that will be temporary, and they are rapidly reversible with treating the underlying cause. Second, it could be the intrinsic renal disease, which is leading to the elevation of blood urea nitrogen or serum creatinine. Third cause, post-renal. Post-renal means bilateral obstruction like prostate enlargement is there, bladder outlet obstruction that lead to the post-renal causes of azotemia. So what we have to do, just look at the kidney size on ultrasound. So if the kidney size is shrunken, it means it is a chronic process. Due to the fibrosis, kidney size has reduced. So it is a case of CKD. Simple step, ultrasound, bilateral shrunken kidney, CKD. While if the size is increased, this is hydronephrosis. So it is due to bilateral obstruction. While if the kidney size is normal, then it could be a pre-renal cause or intrinsic AKI. So AKI, we have to go for the ratio blood urea nitrogen upon serum creatinine. If this ratio came out to be more than 20, then it is most likely a case of pre-renal AKI. But very important, patient should not have taken diuretic prior to the analysis of this pre-renal AKI, because that can affect the serum, the sodium level in the urine. So ideally, before giving the diuretic, we should go for this ratio. While if the ratio is less than 10, then it will be intrinsic AKI. Now let's see some real cases. 67-year-old male with uncontrolled diabetes, hypertension, presented with swelling of the feet and weight is 79 kgs. So this is the parameter which is present here. Look at the blood urea nitrogen. Blood urea nitrogen is elevated. Look at the serum creatinine. Serum creatinine is 2.08. When we look at the ultrasound of the patient, so ultrasound of the patient came out to be normal, so it must be likely a intrinsic renal disease. So the ratio blood urea nitrogen upon creatinine ratio came out to be 15.9. So 15.9 means कि it is not a pre-renal cause, it must be intrinsic cause. Though in the intrinsic cause we have seen कि ratio will be less than 10, but my advice is even if the ratio is normal, go for the intrinsic if the blood urea nitrogen and creatinine are elevated. So we can mark, because these are not normal, these are not normal parameter. So when it is even between 10 to say 20, consider it as a intrinsic renal disease. So it is a intrinsic renal disease. Most likely diabetes nephropathy. Now the second case, 72-year-old male, known case of hypertension, weight is 70 kgs. These are the parameters which are given to you. Blood urea nitrogen is normal. Urea is 38, and you can see creatinine is almost normal, 1.26. Blood urea nitrogen creatinine ratio is 14.3. So when these parameters are normal, then if the ratio is between 10 to 20, then it will be considered as normal. But my question is, what is the estimated GFR in this patient? Male patient, 72-year-old, and weight is 70 kg. So when we take 140 minus 70, age of the patient, multiply it by weight of the patient. So the weight of the patient here is 72. Then divide it by serum creatinine into 72. So 70 to 72 will go, and it will be 70 divided by serum creatinine is 1.26. 1.26. So when we take the GFR, so GFR will came out to be slightly less than 60. eGFR, normal GFR, remember normal GFR is 90 more than equal to 90 ml per minute per 1.73 meter square area. So this GFR is low. So even though the creatinine was coming out to be normal according to this lab range, but the GFR was coming out to be less than 60. So this is a low GFR. Patient is going into CKD. Now patient is 90-year-old female, and body weight is 45 kg. So here you can see the creatinine is 0.62. Because of very low muscle mass, creatinine can be reduced. And when we calculate the eGFR here, so eGFR came out to be 78.9. So will you consider this GFR as a low GFR or normal for her age? So your answer. So you can write down your answer in the comment section, whether this is a normal GFR for her or not. And hint is, after the age of 40 years, GFR reduced by 1 ml per minute per 1.73 meter square area per year wise, it will be reduced. So whether it is a normal or low GFR. Now these are the parameters which are given to you. Female, type 2 diabetes, blood glucose is uncontrolled and creatinine is low. Will you consider this as a normal creatinine? Answer is no. This is the stage 1 diabetes nephropathy. Know this point. Patient has uncontrolled sugars, diabetes nephropathy, and stage 1 diabetic nephropathy is hyperfiltration stage. So this is a hyperfiltration stage. Reason for the hyperfiltration is when the glucose is going through the tubules, it will be reabsorbed by sodium glucose cotransporter. So more glucose is going into the tubule from the glomeruli, and through the SGLT receptors it will be absorbed. High sodium means there will be increased ECF volume, and that stress the atria, ANP released, and ANP cause afferent arteriole vasodilatation. So afferent arterial vasodilatation means GFR will increase, and if GFR is high, creatinine will be low in the blood. It will be low in the blood. So whenever uncontrolled diabetes patient came to you with a low creatinine, do not take it lightly. It can be the stage 1 of the diabetic nephropathy, stage of hyperfiltration. Chronic hepatitis B patient came to you, and a patient has high SGOT, high SGPT, so it is a chronic liver disease. So chronic liver disease, we have just discussed that urea level will be reduced. So this is due to chronic liver disease. There was no other comorbid condition like diabetes. So chronic liver disease means this will be equal to decreased urea cycle, and decreased urea cycle means low urea levels will be there. Alright, so these are the kidney parameters which are given to you, and in this patient present with joint pain, and patient dehydration was there. So because of the dehydration, when you look at the uric acid level, so uric acid level is slightly on a higher side. Though phosphorus is just 0.1 unit high, we can ignore that. So whenever there is other parameters are normal, GFR is normal, only uric acid is high, that can be multiple causes like high protein diet, dehydration can be there, or other risk factor for uric acid will be there. So here the history will suggest the diagnosis that because of the dehydration uric acid levels are high. Type 2 diabetes, frothy urine. Frothy urine means protein in the urine will be there. And look here, creatinine is high. And when we check for the blood urea nitrogen creatinine ratio, look at the ratio 7.54. So definitely there is some intrinsic renal damage is taking place. Renal damage, intrinsic ratio is low. So when we get the urine analysis done, so in the urine you can see the protein levels are high. So patient has frothy urine because of diabetes nephropathy. This is macroalbuminuria which is present because it is detected on the urine dipstick on a normal urine routine microscopy. So this is a typical diabetes nephropathy. Type 2 diabetes, 15 years, present with fatigue, 64-year-old male. And here you can see the urea levels are very high. Creatinine is 6. Definitely it will be a CKD. And phosphorus levels are high. Calcium is low. Due to decrease 125 dihydroxy vitamin D synthesis. So calcium level will be reduced. Phosphorus is high because of the decreased excretion of the phosphorus. And this 135 ALP most likely it will be due to osteomalacia, renal osteomalacia. It can be present here, and rest of the parameter they are almost okay here. So most likely patient has diabetic nephropathy, CKD patient. And when we check for the bicarbonate level, you can see bicarbonate levels are low. So this is metabolic acidosis, one of the important complication of CKD. Now question to you, analyze this report. Patient on hemodialysis, analyze this report, and based on this report, what do you think will be the blood urea nitrogen upon creatinine ratio? So you have to tell me in the comment section whether it is a pre-renal or intrinsic. And second, the same patient has got the hemoglobin done. Hemoglobin is 8.5. So what is the reason for low hemoglobin here? So I will wait for your answer, and if you have any comments, any suggestions, or you want to share your experience, you can write in the comment box. So this was the overview of how to go for a kidney function test analysis. Thank you.